Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Today, we're talking about a few different drugs that you've probably seen in the news. Ozempic, Wegovy, and similar drugs has shown some impressive results for patients trying to lose weight. But it's not as simple as getting injection and then just shedding pounds and not having to do anything else. We're also going to discuss a brand new Alzheimer's drug. So let's just jump right in to morning rounds. Alzheimer's experts are celebrating the FDA's full approval of Leqembi. In a clinical trial, it delayed the progression of Alzheimer's disease by around 5 months. It's not a cure. It comes with risks. We're going to talk about those because joining us now is Dr. Jeff Burns. Dr. Burns is a neurologist at the Memory Care Clinic here at the University of Kansas Health System. More than that, he is one of the best funded, best known Alzheimer's disease experts in the world, not just here, not just in the United States, in the world. He's got a national and international reputation, and he has spent decades researching drugs like Leqembi. Good morning, Dr. Burns. Did I pronounce it correctly?
Yes, Leqembi. Yes, good morning.
Okay, I want to just ask you, is this the new Wordle or Scrabble word because there's no U after the Q? Who decided on that, Jeff?
I don't know. I think they thought that'd be kind of, catchy.
Yeah, it's catchy. It's going to catch me off guard. Okay, so after decades without any good news or very little good news in this whole field, it feels like we're starting to crack open a door. Does this change the world of Alzheimer's research?
Yeah, I think it does, and it does open the door. We think it's a first step. It's not a cure, but it's a first step. So we're excited. I've been treating patients for a little over 20 years, and nothing's changed over that 20 years in terms of how we treat our patients until now. And this is a new drug. It's fully approved, and we're excited to get it, to add it to our list of tools that we can use to fight Alzheimer's disease. But it is a first step, we believe. We think there's more to come.
So recently the FDA had given some approval to another drug that was pretty controversial, but this one doesn't feel like it's quite the same degree of controversy.
No, yeah, there's a couple other drugs that have been in the news. Aduhelm or aducanumab has been around for about 2 years, and it's partially approved by the FDA. And there was controversy, and it's only received partial approval. We really aren't using it. This drug, Leqembi, is fully approved by the FDA, and there's more data, solid data, clinical data that suggests it really does have a meaningful slowing of the disease. We're going to argue about the costs and the risks and all against that benefit, but the clinical benefit is clear in terms of slowing things down on average for people who are treated for this new drug. And that wasn't the case for that first drug, Aduhelm. We didn't have the data to really show that slowing of decline in a relatively convincing way.
So aducanumab, there's so many MABs out there now. I just say I don't know a MAB because I don't know which one I'm talking about anymore. But there's a lot of these new MAB drugs. What is a MAB drug? How does it work? What's going on with this drug? What's its mechanism?
Yeah, that MAB at the end indicates, so lecanemab, donanemab, aducanumab. The MAB is what's important, and that MAB stands for monoclonal antibody. And so these are drugs that are antibodies, which are designed to stick to something. And in this case, these drugs go after amyloid buildup in the brain. And so the antibody targets the amyloid, and then the immune system, when the antibody connects with the amyloid, your immune system sees that and pulls the amyloid out of the brain. So yeah, MABs are everywhere now, these monoclonal antibodies. We heard a lot about them, during COVID. But yeah, so these are monoclonal antibodies, which means they're infusions. They're given through an IV. In this case, Leqembi is given every 2 weeks through an IV and delivered in that fashion rather than, say, a pill.
And how much amyloid actually does it pull out of the brain? What percentage reduction is there, do you know?
Yeah, well, so we're seeing for this drug, and we've been studying these drugs. You mentioned this for over a decade, and the early ones didn't do a whole lot of removal, but this drug looks like it removes it pretty dramatically. Down to actually, we take people who have abnormal levels, and the majority of them, after they're treated for 18 months, the majority have basically normal levels that compare to somebody who doesn't have clear amyloid in the brain. So it's pretty dramatic dramatic reduction of amyloid. That we think that's important, but we don't know how important that is because we don't know what amyloid's really doing in the disease, and that's the honest truth. But what we're seeing with this drug is if we pull that amyloid out, we're seeing that clinical benefit, that slowing of decline. It's not a cure. 10, 15 years ago, we thought if we pull amyloid out of the brain, we may cure people. But it turns out, amyloid probably is not the only thing going on that we have to go after to stop Alzheimer's disease, but it does slow things down.
Yeah, medicine is so darn complicated. Every time we think we know something, it means we just have more to learn. And that's what I think of has been going on for medicine for years. So the drug does come with a black box warning due to some swelling and bleeding in the brain. Talk to us about that.
Yeah, there are risks. And, what we're seeing and have seen with these types of drugs over the last decade is that by removing amyloid, we're putting people at risk for a little bit of brain swelling, some shifting of fluid in the brain. And there's amyloid in the blood vessels. And if we pull that amyloid, we can see swelling and we can see little microhemorrhages. And in this drug, it looks at like about 1 out of 5 people who are treated will have this brain swelling or microhemorrhages. And the majority of those people, so 1 out of 5, who have it don't know it. We see it on MRI, so we're monitoring for that, but there's no symptoms that go along with it. But a few people have gotten quite sick. It looks like maybe 2 or 3 out of 100 people who are treated will get some symptoms, headache, dizziness, and then 1 out of 100 or so, probably a little lower than that, get really sick. And have serious side effects. So there's some things to weigh, weighing the risks and the benefits. We're going to have to really carefully weigh the risks and the benefits on an individual basis in terms of making the decision whether to treat somebody or not.
So who's really the best qualified to receive this drug?
Yeah, okay. The drug's been tested in early stage Alzheimer's or mild cognitive impairment. So it's really looks to be most useful in the really early stages, those early years of memory changes. And so we don't think it helps all that much in the moderate to severe, or it does help in those later stages of the disease. So this is something that it looks to be, right for somebody in the really early stages of the disease. So early symptoms.
So the Medicare will cover, I think, the cost of this drug, but it's a costly therapy.
Yeah, it is. It's costly. Wholesale price is $26,500 a year. And that I'm sure, will be marked up some or a lot. I don't know. But yeah, so it's cost, but Medicare will cover it. That's a big deal. But there is a little catch. They'll cover it if we enroll somebody in a registry where Medicare is able to collect the data and see, are we really having a true impact? And I think that's a reasonable thing for Medicare to be asking, given the cost. And so we'll be enrolling people into that Medicare registry, and then that, Medicare will pay for it. But, there's other expenses not beyond the medication. Like we need to do MRIs over the first year. We're going to do at least 3 MRIs of the brain to look for those side effects. And so, the drug is the costly thing, but then there's other things for people to consider as well. So in terms of making that decision, is this right for somebody? We got to weigh all these, risks and costs with the potential benefits. And, it's not a cure, and not everybody, and it doesn't appear to slow things down for everybody, but it does appear on average to really slow things down for people, as you mentioned, 5 or 6 months over an 18-month period, very early in the disease. The big question is what happens beyond that? Will that benefit expand over time in the years to follow, or will it go away? We don't know. We're hopeful that the benefits expand over time, and so by treating early, we'll have hopefully a big impact for individuals over time. But we don't know that yet.
This is such a terrible disease. I got fingers crossed, and I suspect you're going to be prescribing Wegovy now.
Yes, we got a list of people who are really interested, and I think, my hope and my sort of gut reaction right now, and it's more than gut, I guess, is those people in the really early stages. This is going to be an important thing for us to consider on an individual basis for people with really mild changes that fit the criteria for this drug.
Yeah, that's terrific. So, Dr. Burns, one last question. Are you in your office?
I am.
Okay, I just want to say bless you, because I love it when other people also suffer from messy desk syndrome, also known as MDS, and I have it too. It's great to see. Anytime you want to get on the show and talk about, I don't know, abs or whatever other new therapies are out there, that's awesome. And make sure you're right there, because you can make me feel better about myself. I do appreciate that.
Okay, so I thought about putting one of those screens up behind me to hide it, but they said I didn't need to. So
no, you don't need to. This makes you look much more authentic. That's awesome. Thank you very much for being here. We could spend this entire program talking about this. I'm sure we will in the near future. Thank you so much.
Well, thanks for having me.
All right, switching gears to weight management. More than 2 in 5 American adults have obesity, according to the National Institute of Health, or the NIH. Diet and exercise have been the tried and true advice for patients. Listen, I sit in the clinic all the time, and I say to somebody, they say, what am I going to do to lose weight? And I say, eat less, exercise more. That doesn't go very well. Just to so that there are a few people who are pretty mad at me about that. And you know, as I've gotten older, I understand it, because I exercise all the time. I keep putting on weight. How does this happen? Bariatric surgery is sometimes an option, and now doctors are adding drugs like Ozempic to their toolbox. You've probably heard a lot about that lately. Well, today we're going to have a nice, good, deep conversation about these therapies. Joining us today is Dr. Joanna Finkel, an OBGYN, who also, did I say it right, Joanna? Joanna, I was doing it wrong. Who also specializes in weight management. Thank you for being on the program today.
Thanks for having me.
We also have one of Dr. Finkel's patients, Jana Knight, I said that one correctly.
You totally did, yes.
Thank you very much. Is currently using Ozempic as part of their weight management. And full disclosure, she happens to be a nurse here in the health system who happens to work with Dr. Finkel. So thank you guys for being here. That's awesome. We're also happy to have 2 PhD researchers, Dr. Renee Rogers and Dr. John Jakisik. Yes. I'm on a roll this morning, people. Watch out. Both are from the KU School of Medicine's Division of Physical Activity and Weight Management. Dr. Jakisik has been on our program before. Yeah. He was virtual then, not on live, so we're glad to have him.
Non-messy desk.
Not on the messy desk. Okay, well, you can't be back on the program. Okay, so let's start with Ozempic. It's part of a class of GLP-1 agonists, or sometimes just called GLP-1 drugs. Dr. Finkel, talk to us about how they work.
So they're glucagon-like peptide agonists, and so basically this is mimics a hormone that's produced by the gut, and so then it acts on the brain to cause satiety, and it also decreases like how the food gets processed and absorbed and the gastric emptying. So it slows that down, also acts on the brain, but it mimics one of our own hormones.
Okay, so it's not our own hormone, but it mimics that, and it makes you not, so you're not as hungry because you feel full.
Yep, it acts on that brain and tells the brain, you're full, it's enough.
And you don't empty as fast. Does it make you constipated?
It does have some side effects, so nausea, vomiting, constipation we see in our patients.
All right. Jana, you're using Ozempic, is that right?
Yes.
Okay, now it's not the first drug you've tried for weight loss. What did you try before coming to see Dr. Finkel about it?
So previously I tried to use Phentermin to lose weight and had, kind of some minimal success with that. That's really the only medication that I tried for weight loss, in addition to other different types of diets, keto, Atkins, low carb, all those kinds of things. And, it's just it's a roller coaster with weight.
How did Dr. Finkel and the weight management clinic here at KU, how do they help you?
So Ozempic has been included into, it's a tool in the toolbox, along with lifestyle changes, diet, increasing exercise, maybe changing some of the exercise, not just focusing on cardio, also wanting to focus on strength training, and also providing accountability. So sitting down and really looking at your habits. It's sometimes very difficult to sit down and take inventory. These are my habits, and when you have to do that, you can really do some self-reflection, and then you can work together and come up with a plan in moving forward with that weight loss.
So you've shared some before and after photos.
Yeah.
Yep. How much weight have you lost?
So I have lost about 30 pounds.
That's awesome. Congratulations.
Thank you.
What's your target weight?
So I would like to lose another maybe 15 or 20 pounds.
Okay, that's great. And did you feel better about yourself because of that?
Absolutely.
Yeah.
It's nice to feel more comfortable in your clothes and not just, constantly be, tugging around to feel comfortable. So definitely feel a lot better.
Yeah, congratulations.
Thank you.
So, Dr. Finkel, how has Janet been doing as a patient?
She's a fabulous patient. I mean, she's a model patient. That's why I asked her to come, not just because she's actually my nurse. But we talk a lot about the importance of protein and hydration with these medications. And, she is able to accomplish those goals. She gets 60 to 80, grams of protein and then 60 ounces of water. And she's constantly a good model for my patients, counseling them through it. And she does her strength training. She actually teaches classes for exercise, and I've attended some of them, and she's wonderful.
She does a great job.
Yeah.
All right, that's awesome. So, Dr. Rogers, what are your thoughts on GLP-1 drugs for weight loss?
It's I come from the background of lifestyle weight management interventions, all the things you talked about, thinking about your eating, thinking about your exercise, how we put those together comprehensively, and think about our mental health with it as well. And so when they first came out, I was like, okay, this is different, because we've heard our patients talk about not being able to stop their hunger as much as they've tried all these different diets. And this is really a great opportunity to clear some space to do all the wonderful things that Jan talked about. It's really important. So I think it's an opportunity to do better and help more people, honestly.
Yeah, that it is a really great thing, because obesity is an epidemic here in America. So tell us about your sense about this whole class of drugs, and what does it mean for the challenges that Americans face around obesity?
Well, I mean, I think it's a game changer. It's clearly a game changer when major weight loss companies are buying in. People that have not been buying in are buying in. These are very, very powerful drugs. The challenge is of course for some people cost, but I think people also have to remember that just like eating and activity behaviors need to be lifelong, these medications in some layer might be a long-term kind of thing. There are studies that have come out when people come off of these medications, what's happening. And what's happening is similar to what we see in lifestyle programs. People start regaining the weight and regaining it pretty quickly. So I think that what we're thinking about in our space is lifestyle from an activity and eating perspective is still really important, but we need to reposition it within the context of these pharmaceutical agents that are now very, very powerful. Individuals who are on them have less appetite, but what we're hearing from patients is maybe they're now not eating enough. Maybe they don't, so we have to reframe this. The weight loss is coming off. Well, maybe I don't have to be as active. Well, in reality, you probably do, but maybe you don't need to be as active as we were thinking you needed to do before to manage your weight. So it's a game changer in so many spaces, and we're trying to get ahead of it.
I hear you say, so talk.
Because obesity is a chronic disease, and so I explain this to patients. I use the model of hypertension. If you have hypertension and you see your cardiologist and they tell you, okay, we're going to start this medication, but you need to stop your smoking, lose weight, and eat better. And the patient says, okay, I'm going to do that. Comes back 6 months later, lost weight, stops smoking, ate better. Your blood pressure not normal, we're going to take you off of that. Some stressor happens in that patient's life in the next 6 months, perhaps a death, a change in a job or something. They take up smoking again, gain 20 pounds, eat poorly, come back, blood pressure's up again. You start them up on medications again. It's a tool, but weight is going to fluctuate through people's lives, and it's a set point that's set, for patients with obesity. It's reset, and to bring that down is what we're having trouble doing, and that's where the area of research is also important, is how do we get that to reset permanently?
So can I just ask a question? I'll just open up to all of you guys. Why? Why is the body, why especially is this in America, and why are we struggling with it when other places don't struggle so much?
Do you want to start?
Well, there's a lot of reasons, and I'm part of the National Academy's Roundtable on Obesity Solutions. And when you start to really dig down deep, we can blame genetics, we can blame physiology, we can blame, when in fact it's systems that talk to one another. And it's all of the above. Our genes are set up to be, somewhat thrifty. When we're thrifty, what happens? And we're in an environment where food is abundant and activity is easy not to do. It's going to be promoting this. So we have to be looking at systems and not one solution for this whole thing.
So just historically, food wasn't always abundant. It was hard to acquire, and you had to be active to get the food. So our bodies are built for that. They're not built for being able to say, I'm just going to the store, I'm going to buy McDonald's and grab my, old French
And our
fries.
food, even our content, is very processed as compared to sometimes other countries. But obesity is a worldwide epidemic. I mean, it's been increasing throughout the world, not just here.
And we can't all blame Ronald McDonald.
No.
No. Good. So what do you, any thoughts you have about what other answers are there to this obesity epidemic?
I think there's a lot of, when we think of the mental side of it as well, we have to consider it, because I think for some folks that have been living with obesity for a long period of time, they start to see that there's these negative thought spirals. They get into patterns. It becomes hard to break those patterns. So we have to be really empathetic to that as well. So while there's a biological side to all of it, there's also a very strong behavioral component to it that it becomes tough to find the way out of, and quick solutions with diets don't always work.
So Janet, does this all sound familiar to you?
It does, from a personal side and from a nursing side. Just yesterday we had a weight management clinic, and I had 2 patients cry with me. Mm-hmm. One was happy tears, so there was like the positive, like mental, I'm so proud of myself. So there was that, and then there was the opposite side of things. She'd been doing really well, but a couple weeks ago she got really stressed out and she was eating her feelings.
Eating her feelings.
That's exactly what she said. And she's like, 2 weeks ago my weight would have been better, and so really focusing on that and listening to patients and validating that and trying to help them find those types of solutions. And yeah, I've experienced that myself as well. You do feel better and you do have more confidence, when you're more comfortable in your skin. And unfortunately, weight does play a big part of that.
Yeah, what a remarkable story. So we've talked about how it probably means people have to be on these forever. Is that your sense?
So I may say on and off, or you may be on some sort of medication, because these GLP-1 agonists are just one of the various types of medications we have. They are clearly right now the most effective. There's other ones coming through the market that will soon be pills that are in phase 2 trials.
Yes.
And
always better than an injection, right?
Right, and they should be less expensive as well. But these are, again, there's other medications. Wellbutrin has been classically used. So I change the medications as the patient progresses, and then we may jump back on them. So they're tools, but again, what we work on is, like Jana was saying, habit changes, strength training, like you guys were saying, behavioral changes, and lifestyle. And if we are able to make those within the span that they are on the GLP-1 agonists, then it's less likely to regain. And that's what the studies may show in the future.
So the European Union's version of this, the FDA is investigating 3 cases patients who are on Ozempic who had thought about suicidal thoughts. Now, there's not been any proof yet that the drug causes suicidal thoughts, but in the U.S., the prescribing instructions for Wegovy say that patients should be monitored for thoughts around suicidal behavior in that way. Thoughts from your standpoint?
So that is something that is in the general warning that we provide with patients with Wegovy or Ozempic, to discuss with them about if they start to have suicidal ideations, they need to reach out to their providers. But we also counsel about other risk factors and side effects that are more common.
So Dr. Finkel mentioned, I'm sorry, I kind of keep all the names straight all the time. I think I got it right that time.
You did.
So mentioned some new drugs and things. Are you guys doing some research and testing on new therapies?
So we're actually we're working actually pretty closely with some colleagues at other institutions that are really kind of at the front line of these developments. And we're hearing about the triple G drugs and other things that are out there. So what our philosophy is right now is, one, it's really hard to get even the medications for research purposes. So what we're trying to do is naturalistic experiments where we're trying to take patients who are through our weight loss clinic who are getting these medications and trying to see what's changing in them so we can better understand how to better treat patients. So that's our goal right now until we're able to get a lot of this ramped up.
You mentioned the mental health aspects of that. Yeah. This has got to be really a big part of this whole weight loss program.
Yeah, absolutely. And so much of it is patients, trying to figure out their, managing their behaviors. It's a big thing. Feeling guilt, but also what they're hearing from the outside right now, I think is quite fascinating. They talk about going on social media and the people that are very much against it, and then other people that are very much in support of it, and really struggling to know where to get the right information from. And that's something that, is it okay that I'm taking this? Is it right? Is to have this, extra agent, and really taking some time to talk about that is probably something we should be managing in the clinic as well, to really say, like, I know you're feeling this way, why are you feeling this way, what things are getting in the way, not only for yourself, but what are you hearing from the outside that may be impacting the way you feel?
Yeah, it's an interesting thing. So, one of the things, so I'm older. I'm sure I'm the oldest person in this room at the moment. So I practiced during the era of fen-phen and did a lot of pulmonary disease and started the pulmonary hypertension clinic here many years ago. And fen-phen ended up causing lots of heart valvular disease, lots of pulmonary hypertension, and we had to work our way through that, and we saw the difficult side effects from it. Any sign of any of that with Ozempic so far?
So there is a class of patients that we don't prescribe it for, anyone who's had a history of medullary thyroid cancer or MEN2 syndrome, and we screen for those. Those are, increased risk of thyroid cancers. But overall, what I counsel patients about is that there are risks to having obesity or being diagnosed with obesity, which means the risk of endometrial cancer is one of them, specifically in my field, and then breast cancer. And so it's not without any risk to have obesity as a diagnosis. And so these medications offer an opportunity. Plus, we've known about these for over a decade, because they've been used for diabetes, and so now they're transitioning to weight loss.
Yeah, I think, and one thing that we know is that American Home Product, who had fen-phen, also covered up a lot of the data, and now I think we have a lot better data monitoring than we had back then. And I think the Ozempic is a lot better. All right, so let's check the COVID count. But first, reminder for all of you to send in any questions you have to either YouTube, Facebook, Twitter, or email the Medical News Network. We'd love to get those questions. We'll be happy to answer them. Let's move now to the COVID count with Dr. Dana Hawkinson. Someday it's going to be 0. Not quite there yet.
No, I think we're getting close. We've had 2 active cases the last couple days. Today, we have 3 active cases, 7 total, but 3 active, 2 in the ICU, 1 on the ventilator, and I would say I was able to go through those 2 that we had initially the first couple days of this week. 1 was incidental, but the severe case did have multiple comorbidities, including age, heart disease, kidney disease. So it is that type of patient with those comorbidities that we do expect, unfortunately, to have the highest risk for hospitalization and severe disease. But, it's unclear whether that patient was fully vaccinated at this point in time or even got Paxlovid as an outpatient. We know getting Paxlovid as an outpatient, especially for high-risk patients, does reduce your risk of hospitalization and severe disease as well.
Yeah, a couple of quick thoughts about it. First, this is a nadir. I love this number.
Yeah.
Let's keep it there. I'm sure the fall will be a little different. Second, evidence coming out in Nature now that deer are a reservoir for COVID. Did you see that as well?
Yeah, just listen to some other podcasts and other scientists speak. We always talk about zoonoses, which is the infections spilling over from animals to humans, but unfortunately humans seem to be the biggest risk, and there's actually reverse zoonoses which occur probably and are bigger risk to animals rather than the actual zoonoses. So we know that the coronavirus, SARS-CoV-2, now has a strong maintained population or circulation in deer populations for sure. Yeah.
So my cat, has been sneezing lately. Hope it's not COVID. Hopefully the cat's not going to give me any COVID.
And we know, various zoo animals have been found to have infection. We know that household pets, domesticated animals, dogs are less likely to have the infection and active replication. Certainly cats can. There are a number of different mammal species which can as well. So it is a concern. And now, we're kind of opening that up not only for SARS-CoV-2, but we know this can happen for other infections, particularly influenza and other viral respiratory diseases as well.
So interesting article in New England Journal of Medicine this last week, I think, where they talked about Paxlovid again, supporting the use in those of us who are older. I think I may hit that age category, but also in younger folks with multiple comorbid diseases, but not in otherwise healthy folks.
Yeah, I think that's exactly right. And we always have been going back to high-risk patients. Just in general, like you said, certainly age is one of those things, but other comorbid conditions. Immunosuppression is a major issue as well, but things like heart disease, kidney disease, lung disease. We know that Paxlovid doesn't offer the greatest benefit if you are vaccinated and say under 50. We have good data to support that. But if you are some of those other populations with those issues, with those comorbid conditions, Paxlovid does help and is very good at reducing your risk of hospitalization and severe disease. So it's still a very good drug. I know that infectious disease and my colleagues, we are always concerned about resistance. Right Right now, though, we know that Paxlovid still clinically works. There is not large-scale resistance going on. So I think if you are one of those people with high risk factors and you get diagnosed with COVID-19, it is vitally important to get evaluated by your medical professional and really get on Paxlovid if you can.
Yeah, that sounds like great advice. Hey, we've also got a good email question about vaccines from Jason. He asked us, why do we think the public health recommendations for COVID boosters ignore their use to prevent long COVID?
Yeah.
We know that these vaccines can help reduce severe disease, hospitalization, and death. Those are great things we want to do, of course, but it also shows that long COVID can be reduced. We don't talk about that so much.
Yeah, I think this is a multifaceted answer. So first of all, it was never studied for that. Do you remember, Steve, when the vaccines were first evaluated and studied? It wasn't studied for that. So it's very difficult.
We didn't even know about it as much back then either. So,
correct.
Right? Yep.
The question wasn't asked. It wasn't evaluated. It was only after, in that post-marketing, which again, we've always stated that we continue active surveillance on the vaccines, on their safety profile, and it continues to have an excellent safety profile. But that question was never asked. That was never studied. It was only after that fact, when we knew the impact of long COVID, number one, on the population and on an individual, but also we had enough data to support and look at those numbers that we did see a reduction in long COVID. But again, now the waters have been muddied as well because we have moved on from just that primary series onto multiple boosters. And in that time, people have also been infected and reinfected as well. So the data does support the fact that probably a 15 to a 30% reduction in your risk of long COVID. But I think that's a very good question that was asked, but that is probably the main reason, is right now the waters are so muddied with all of these other boosters as well as infection and reinfection. And again, that question was never initially asked nor studied. So it is just maybe an extra benefit that we have found from the vaccines.
Yeah, well, and hopefully as we develop the new monovalent vaccine, which we're forecast to come out, I think, in September, we'll also be talking about some of those aspects of long COVID because we do know more.
Yeah.
Hey, you like to go outside and run and jog, right? You're an outside guy.
I do.
Yeah, you have this hot weather and this kind of air quality stuff bothering you right now?
Not too much. I ran on Monday. I was outside, and I think this weekend I was okay. You know, I prefer the warmer weather compared to the 20 degrees in February, but I was okay. So
yeah, we do know there's people out there with some lung disease like asthma, chronic obstructive lung disease, emphysema, etc. So people with underlying lung disease are bothered by hot weather and by some of the decreases in air quality. Now, fortunately, we've not seen what the Northeast has seen around the Canadian wildfires, but we do know that it has caused some more difficulty. We're seeing that in some of our people with chronic lung disease. But also, it's a little like walking into a wall. If you keep walking into a wall, you know it hurts, you're going to stop walking into a wall. Most people with chronic lung disease tend to have a lot of avoidant behaviors around hot weather and bad air because they know those things are going to make their breathing harder. So fortunately, we don't see as many exacerbations. Like a lot of folks stay inside when they can. But for people without air conditioning and people who are in high-risk, vulnerable areas, this hot weather and worse than air quality can be a real challenge. So just remind everybody out there where you can have a fan, try to avoid it as best you can, and drink lots and lots of liquid. Alexis Del Cid, there are questions out there, I suspect, from today's panel. Let's hear them.
So many questions, and we're also getting some really good questions about Alzheimer's drugs and Leqembi. We are going to get those questions answered at a later date. We're going to get those to Dr. Burns. He's very accessible. So don't worry. We've read your questions.
You did not want me to answer those questions. So we'll let
you know what? We'd be
let
confident.
Burns do that one. Yeah.
All right. We do have some excellent questions as well about the weight loss drugs. I'll get to the first one from Yen Liang, who wants to know if the weight loss drug can help cope with insulin resistance.
Well, actually, that's part of what it was designed for, right?
Yes, so it does help with insulin resistance. Wegovy, Ozempic, the new one, Mounjaro, which is going to come out hopefully at the end of 2023. So they will help with all that. I deal with PCOS patients because I'm primarily OBGYN.
Tell us what PCOS is.
Polycystic ovarian syndrome. And so there is a large facet of insulin resistance without necessarily frank diabetes in that subgroup. I will often use metformin as well in addition to the Wegovy to help even improve that insulin resistance further and change their metabolism. So that's a good question.
It's great.
Sharon Delosier has another question. Sharon Delosier has one specific to Wegovy. She says she has been taking Wegovy for a few months, but the lower dosages are unavailable. Now, I've been taking for the past few weeks Ribellesis. Am I saying that right? It's a different drug temporarily. She's not diabetic, and it's very costly. So what does she do?
So I get that's a big problem right now. So unfortunately, Wegovy in any sort of dose is completely out until I understand October, November. They're having troubles with production. And so I've been switching patients to Saxenda, which is another weight loss drug, but the problem is now that one is also unavailable. So as you can see, we're having trouble meeting that gap. And so often I will have to place patients on there's other medications. So if she talks to her provider, I've been bridging patients with medications until we can get the Wegovy supply back up, and then figuring out where to start them back. But this is just a bump in the weight loss journey, and I try to tell patients this is a marathon and we have to take steps towards it. And so just reaching out to their provider and seeing what is an alternative until we can get the Wegovy supply back up, and just staying on path in terms of behavioral and lifestyle changes.
I think one of the things people have to understand is that these drugs were never meant for weight loss initially.
Yes.
Right? They're meant for diabetes management. So that's this many patients. When you throw in weight loss, it's this many patients. And so these companies had and it's escalated. The demand has escalated really rapidly over the last year. Their production was never meant to be here. It was meant to be here. Because you don't want to overproduce drugs because they sit around, they expire, it's costly. But now they have to ramp up to get there. It takes time, and the FDA is real strict about making sure your manufacturing standards. We heard earlier this year, the FDA closed down a plant in India for American use because it didn't meet manufacturing standards of a different drug. So it's just a big deal. So
it's unfortunate because there's a lot of, if you're on social media or things, you can hear a lot about Groupons and things for getting semaglutide, because Wegovy, Ozempic, they're brand names, right? Ozempic is for diabetes, Wegovy is for weight loss, but they're all semaglutide. And so I've seen Groupons advertising semaglutide from compounding pharmacies, and I want to really discourage the public from using those because unfortunately they're not safe and they're not meeting the guidelines that are set up by the FDA. So they may have other compounds that may have adverse side effects.
And we said people sometimes get frustrated at the FDA. I just want to say the FDA does a great job at keeping the American therapeutic pipeline safe, and I don't think they get anywhere near enough credit for the hard work they do. Alexis.
I have a great question from Sharon Chapman Whitlaw. She wants to know, do you have to take larger amounts of Ozempic to lose weight than the prescribed amount for diabetes?
You're prescribing it.
So no, we started up slow, and so what the difference is the titration and tolerance. So if I have a patient, I'll start it at the 0.25 dose, and then you can go all the way up. But the problem is tolerance. Will patients have a lot of nausea, vomiting, dehydration? You have to meet with them often, and that's why we're prescribing it, because we want to make sure that how does the patient look? I'll meet with the patient and see, take their history, their dietary history, their intake, and their exercise, and then determine, can we go up or are we good there? Are you losing enough weight at the 1 milligram that I don't need to have extra side effects at the 1.7? So it's not going all the way up. It's just deciding on a case-by-case situation.
Okay. I have a vaccine question. This one is from Katie Allison. Katie wants to know, do I wait until September for the new vaccine, or do I do my second combo shot now? I have an autoimmune disease.
That's a great question, Hawk. There's not a lot of disease out there right now. Bivalent doesn't look quite as effective against some of these variants. But is there harm in taking another shot?
There's likely no harm. We have people with multiple vaccinations because of things like immunosuppression. But I think, just as you said, Steve, there is not a lot of circulation of the virus. I would probably encourage just to wait. We're nearing that time when the vaccine is going to be available. Certainly always talk with your individual healthcare provider, but I think holding off and waiting until the new monovalent booster is available is probably the best option. If you do happen to have symptoms, I would get tested as early as possible and then speak with your provider about getting on Paxlovid as well.
And I think it's always an individual decision. I'm 63, have a history of prostate cancer, a few other medical problems, and happen when you get a little older, and I'm waiting for the monovalent vaccine to come out. I'm very much, I'm going to get my vaccine, but I'm waiting right now for monovalent just based on the data that's out there and the low level of circulation and trying to stay healthy with other activities.
Yeah.
Fran has a really good question. I'd love to know your take on this. Fran writes, I've heard BMI is not a great measurement, but it's still being used. Why?
Okay, guys, research folks, talk to us about this.
Well, we will, and actually we are presenting an abstract on this at the Obesity Society meeting in the fall. Yeah. You know, there's a lot of controversy around this. BMI is an initial screening tool. It's not a diagnostic tool. It just simply suggests that maybe there's something more that needs to be dug in and looked at. You know, and it's an easy measure, height, weight, easy to measure. There are more complex things. A lot of people say, well, why don't we do a waist circumference? In our hands, in research hands, we have variability in how that measurement is done. And we can only imagine what would happen when you kind of don't standardize it in a clinical way. And it's kind of like, you know, just throwing, you know, more fuel onto the fire. So we see BMI as a good initial screening tool, and then the clinician digs deeper when that BMI is a little higher to see is that BMI really a health risk for this patient or not. The one challenge that I think is coming up in this space, and we're talking a lot about this, is at this moment in time a BMI might not be indicating that a person has, you know, other risk factors. But it's the length of time that the person is exposed to that high BMI that might be the problem. So it may not be a problem today, but if you stay at a high BMI for 10 years, that's where the problem could be. So there's a lot of controversy here, but we still think it's a good initial screening tool.
So Dr. Rogers, I saw you shaking your head.
Yeah, I think, you know, it's not perfect. We can call it what it is. It's absolutely not perfect. But at the same time, we have to start somewhere, and if we're completely ignoring the issue, we may not be doing the justice that it needs. But I think it also comes down to the context. Just telling someone that they have a high BMI and leaving it at that isn't always helpful, but really talking about everything we've been saying today, the profile, the risk factors around it, but also what are you doing in your lifestyle? Can you be moving more? Having a really deeper conversation of everything that goes around the BMI could really be meaningful.
And the other thing I think of the BMI, it could be different at different ages,
Yeah.
and it doesn't. Most of those nomograms don't adjust for that.
That's correct. That is correct.
I try how I make myself feel better, because I was complaining and whining these guys before the program started up, and I'm about 25 pounds in the last 40 years, and I just don't understand it. Who designed the human body like that? Well, whose plan was that? All right, Alexis, I'm done whining
this one's great.
for the moment.
It is got a question from Lee. Lee wants to know, how do the doctors feel about the health at every size movement? The idea that obesity isn't something that requires treatment. This has gained a lot of momentum, particularly online.
All right, let's have a good conversation about this. First of all, I'm going to ask you what you think about that. You educate patients about this all the time?
So on one hand, I definitely agree with that. You know, we're not just looking at weight, we're also looking at labs. So you're looking at cholesterol, you're looking at, you know, thyroid levels, et cetera, et cetera. And so, yeah, there are healthy individuals at different BMIs, and then there's also the mental health aspect as well. So that comes into play. I know for me, you know, I may look very healthy, but I also deal with hyperlipidemia or high cholesterol. So starting the weight loss journey hasn't just been about losing weight, it's also about making myself healthier. And in my case, lower weight is also helping out those other issues. So like my cholesterol in the last 4.5 months has gone from, you know, do I need to be on a statin, to within normal ranges. My LDL has gone down. It still needs to go down a little bit more. But health definitely looks different depending on other risk factors. But as we've kind of talked about, BMI isn't the only thing that we're looking at.
But we also know that patients who have a higher BMI or have a long-term history of that, they tend to have other health risks as well.
Yes, and some of those health risks can be, you know, like I had mentioned before, endometrial cancer, breast cancer, a lot of other cancers are associated. There's higher risk of high blood pressure, diabetes. You know, I can go on, infertility in terms of my particular specialty, increased risk of miscarriage, and then I particularly look at pregnancy outcomes. And so there's higher risks of C-section, higher risk of preeclampsia, So trying to modify those risks prior to conception is important. But I also understand the movement, and I'm very sympathetic to that movement and why it's occurring. I don't think I'm out there trying to find patients to change it. Patients come to see me because they have been identified as having medical problems associated with their weight, and they want to make a change. And I don't focus so much on like a BMI or a weight that they want to achieve. I don't particularly, subject them to where do you want to go with this weight, but how do you feel, and how do you feel now after you've lost some weight? Is this kind of where you want to be? Sometimes I get different goals from patients. I ask, what's your goal? One patient told me she wanted to get on a horse and she couldn't because she weighed 230, so she needed to lose 30 pounds to be able to get on the horse because that was the rule. Well, we lost 30 pounds, she got on her horse, she bought horses. Those are the goals that people want to achieve, and I'm there to support their goals. She had a normal metabolic profile. It's where you're at that makes you happy. It's called a happy weight, and I'm okay with that.
And I think you also have to understand, as long as you know what the risks are and you accept that, that's
exactly.
okay. It's kind of like saying, well, I don't want to take the vaccine. Okay, just understand what the risks are. I don't want to wear a mask. Just understand what your risks are. And I with my folks, the patients I see, it's kind of the same discussion. If you're comfortable with where you are in weight, that's one statement. But understand what all the risk factors are with that weight, whether that weight's too high or too low, because you can also incur a lot of risks if your weight's too low. And we're not trying to say everything has to be about you to be perfect. Our job is just give you the facts, and then you decide how that fits your own personality, I think, and how it fits your own profile.
That's correct.
Alexis.
This has been such a great
Anything
discussion.
else? Okay.
We have many questions as well on the Alzheimer's, but again, we've seen your questions, and we will get those to Dr. Burns for you. We'll find a way to get you those answers.
I'm going to ask you a question about fitness trackers, because you and I talked about this last time. What do you think?
They're actually not fitness trackers, they're activity trackers, because they're not measuring fitness, they're measuring how much people move. I think that they're very good tools in the arsenal of letting people know how much they're sitting and how much they're moving. But we've done studies that show that they are not the be-all, end-all. I mean, I'm wearing 2 of them right now, because we're testing some of these things. But it's not that you have one, it's what you do with the number. And I think that that's really important. So it's a good feedback tool, but simply wearing one isn't just going to get you active. There has to be something behind that.
Yeah, you got to be motivated across the spectrum, right?
Exactly.
Well, let's get final thoughts before we end our program today. I'm going to start with you, Jana.
I guess thanks for bringing me on to share my story, and hopefully it can maybe help somebody either reach out for help, find a provider, and think about the medication not just being the cure or making things better, but really thinking about it being a tool in your toolbox along with the other lifestyle changes that need to be made so you can have that long-term success.
All right, and thank you for being on the program today. It does take a lot of bravery to come and share your story. You did a great job.
Thanks for having me. I'm super excited about all the new medications that are coming on the market, and I'm happy to treat patients. I think that you should be confident of the drugs that we use. We have been studying them for more than 10 to 15 years with patients with diabetes, and so if you're interested, please seek out a provider. But remember that obesity is a chronic medical condition, and so it is not something, a lot of patients take that in and it's like, what am I doing? I should be exercising more and eating less, and therefore it's my fault, and it's really not. It's a metabolic condition, and we're here to help.
All right, thank you. Dr. I don't know, I can't who's going to go to next. Dr. Rogers.
No, thanks. I think the one thing everybody at this table has said so many times, which is very encouraging, is that while these are so exciting, be comprehensive about it. Still remember that paying attention to your healthy lifestyle behaviors in partnership with this medication is the way to go. And if you need support, you need help, reach out to those folks, ask questions of your providers, and to get the lifestyle support around the medication that you need, because definitely people are out there to help, and we want you to be successwe're
All right, Dr. Casey.
Yeah, I think this is a very, very exciting time, and there's a lot of great clinical work going on, but I think what's really exciting for us on the research side is, as we're actually at KUMC getting ahead of this and actually being a part of the discussion about where do these medications go next from a research side and the next generation. And so it's a really exciting time, so I think you can get really great care here from an obesity metabolic treatment perspective, because we're on that cutting edge.
Yeah, it's been a great discussion. I really appreciate all of you guys for being here. It is terrific. Doc Hawk.
Yeah, just echo what our panel has said. You know, health is more than just weight and BMI. Certainly we know that these new medications do significantly help with that, but we know that it is multifaceted, and you and I have talked about this, and you've talked about this on your show, Steve. Just very many factors. So, you know, people always ask us, what can we do to be the healthiest we can, to have our immune system the best that we can? You know, things like this, certainly reduction in weight, but the healthy lifestyle of activity, good sleep, good nutrition. Of course, those preventive methods as well, like vaccination. We heard the question about vaccine today. So vaccine, being up to date with your vaccines. And what you always say as well, those pillars of infection prevention and control go with you wherever you are. Understand that situation that you're in and those risks that you're in. And also remember that good, adequate hand hygiene frequently. All of those things in combination will help you live your healthiest life.
You know, this has been a remarkable program, Alexis, because we have had such cool folks on, and we've had two remarkable stories, one in Alzheimer's and one in obesity. You know, as a younger man and as a younger physician, I probably didn't take the right approach on obesity. I would just say to patients, eat less, exercise more, thinking that was a simple answer. And it was a simple answer, but it was probably an ignorant answer. And as we've understood this story so much more, in which such a great job our panel's done today explaining, and I want to thank them, and I especially want to thank you, Janet, for coming onto the program and talking about your experience. And knowing that it's really, it is so much more complicated, and then the therapy for it is so much more complicated, and how we approach it, we have to really approach it as a disease and all the ramifications of it. Just like I think Alzheimer's is so much more complicated than just getting old. And so at the end of the day, we keep saying the same thing. Faith, hope, and science, when they're roped together, perform a really strong bond. You've heard about it today in two remarkable developments in two very difficult to manage diseases, and from a great story from our panelists. Well, thanks to you all for being here, and keep remembering that combination of faith, hope, and science, man, it can bring a lot of good days ahead. Thank you all so much.
Coming up Friday on the Morning Medical Update.
Bladder and bowel problems can be embarrassing, but that shouldn't stop you from seeking care. I'm Alexis Del Cid. On the next Morning Medical Update, we explore pelvic health, where most problems tie back to your muscles, the exercises, breathing techniques, and diet tips that keep the groin healthy. Friday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.